the prize in the first before the beginning of the first session, because I know that Iowa or wherever those folks were from, that's a long way, but we have with us today, for our next speaker, we have Adrian Zacher. He's a pioneering figure in sleep health. He's dedicated to improving the quality and accessibility of sleep care through community pharmacy. I thought this was going to be an interesting topic for us because it's a channel for us here in the US that we don't really take advantage of from a sort of a patient acquisition standpoint. But Adrian, as the CEO and founder of the British Society of Pharmacy Sleep Services since July of 2021, he leads a charitable organization that equips pharmacists with evidence-based training to address sleep disorders like insomnia, sleep apnea, and narcolepsy. Through the BSPSS and his initiative Snorer Pharmacy, Adrian empowers pharmacists to screen and manage sleep-related issues, enhancing patient outcomes and reducing NHS costs. As the founder of Snorer.com for over 13 years, Adrian disrupts misleading snore cures marketing by providing independent device-agnostic guidance and professional training. Since February of 2025, he served as a health influencer for the World Health Organization, combating misinformation and promoting credible health content. Additionally, as a task force member of the All-Party Parliamentary Group for Sleep since April 2023, he advocates for better outcomes in sleep disorder management. Adrian is also an accomplished author of gripping sleep awareness thrillers. His novel, Doze and Die, exposes the stark realities of sleep disorders in a compelling thriller format. If you haven't read it, you should. It's a great read. You'll not want to put it down. It's called Doze and Die. Let's see, available in Kindle, paperback, and audiobook. His latest book, Overdosed, released August 2024, is a hard-hitting thriller inspired by real events tackling counterfeit sleep aids laced with deadly opioids. Available in paperback and Kindle, it blends suspense with social commentary on addiction and modern life fragility. Adrian, it is so great to have you with us today, and he has been a guest on my podcast, the Sleep Tech Talk. If you want to learn more about his story in particular, feel free to check out that episode. But Adrian, thanks for joining us today.
Thank you very much. Can you hear me?
We've got you. Yes.
Lovely. Okay. Hello, America. Wow. Thank you for the fabulous and very kind and generous introduction and the welcome. And thank you for having me here today. So I'm here to talk about the patient journey to care. And I'm going to look at this from a global perspective, but then narrow down a little bit to what's going on in the UK as perhaps an example. And the reason that I'm here to do this, well, actually, let's just talk about who I am. So I'm going to say that the addition to the very kind and generous introduction from Robert is that I'm actually doing a PhD at the moment with this incomprehensible sounding university. That actually means the Free University of Brussels. I can't pretend to pronounce it. And my PhD focus is on clinical decision making in community pharmacy with regard to sleep disorders, and we'll get into why in a moment. So I think it's important to say what I'm not. My interest is pharmacy and what they do and how they help, but I'm not a pharmacist. I'm not a medical doctor. I have 30 years in the sleep industry. I began as a dental technician, and whilst making things, I became an oromaxillofacial surgery technician. That's elective orthognathic surgery to change people's faces so they can breathe. The only other option at that time was a tracheostomy. Anyway, so let's dive in. So I'm going to challenge you all. 80% undiagnosed. So for at least the 30 years that I've been involved in sleep, we've had that same statistic. 80%, perhaps 90% of people with obstructive sleep apnea remain undiagnosed. It's appeared in journals, funding bids, conference talks like this. But repeating a problem doesn't solve it. So I want to ask us, are we still okay with that? Because are we actually trying to fix the sleep crisis, or are we just comfortable describing it? The solution I propose might not be where you expect it. So we have I mean, this data, I mean, I've seen 150 billion in annual healthcare costs for untreated OSA in the US. I'm going with 94, but you know, it's a staggering amount of money. And then we can get into what goes on in community pharmacy and OTC misuse. We've got long-term use of short-term drugs because, well, we're going to get into why in a moment, into why this is happening. And then there's this blind spot that I had. I put my hand up. The patient journey begins with what you call the PCP, or we'd call it the general medical practitioner, the GP. And the journey begins from there. But that's not actually true. People are presenting that we can meet them where they are in community pharmacy, and that the pathway, I suggest, is fragmented. And what that means is that we have a really high patient burden in underserved and rural communities and coastal communities, and they just don't have access to evidence-based, informed help and care. So it's a huge missed opportunity and obviously the worsened outcomes. So I put it to you that community pharmacy has a role, and I think we should open our mind to it and look bigger than and wider than beginning with the primary care practitioner. Okay, so that's my lens on this. So it's a decision making by pharmacists in sleep health contexts. So I'm an educator, I'm an advocate. As Robert said, I'll pay you later for promoting my book. Thank you, Robert. Or several books. There's a new one coming, by the way, called Sophia, but we'll get into that if you're interested. So yeah, I'm a member of FIDES, that's the World Health Organization. I'm advocate for better information, promotion of evidence-based information. I set up the charity, the British Society of Pharmacy Sleep Services, incredibly long name, and I'm doing the PhD. I contend that community pharmacy may well be the missing link. And I put this to you, why? Because if you've actually just walked into a community pharmacy, you'll see this is where people are. They're there, they're buying these first generation sedating antihistamines. They may be buying earplugs or gum shields for snoring or strips to put across your nose. So it's the trivialization of sleep. And I contend it's the exploitation of the naive for profit. But the problem with it is it's not just exploitation of the general medical practitioner. Vendors are exploiting the education gap. Now, primary care has very little knowledge, not like you guys. You guys are asleep, but you know it. But primary care, if they've had any education or perhaps more than a couple of hours as part of their undergrad education, they're quite lucky. And there's been research that shows that some have zero sleep education before they become graduated as a pharmacist, even GPs, general medical practitioners. They know so little unless they've done some follow-up study. So vendors of OTC products will exploit that gap to push products with little, if any, evidence to support their place on the market. And then what happens? It means the general public get products that are plainly not going to help them, are delaying them from actually accessing real help and real care. And the thing is, they don't know what they don't know. Now, if we look at this globally, excuse the awful graphic, but the point is the whole thing is changing. So what we've got is historically pharmacy were pill dispensers. They were OTC advisors. They followed a script, had a prescription given to them, fill the script, give it to the patient. That was the limit of their role. You had no real involvement. Now, around the world, that's changing. And they will use mistakenly the word diagnosis, and I know that everyone will hold their throw their hands up in horror. No, I'm not suggesting they do a PSG and diagnose someone with OSA. But in the few minutes that is there with a patient and a pharmacist or pharmacy staff to speak with a patient, they call that consultation a diagnosis, because then they'll go on and supply. Yeah, so it's not great, but I just want to clarify that. So, but that's the past. And as I say, around the world, different countries are at different rates of evolution. And we can go from, I'll give you two examples. So in Scotland, there's a thing they call Pharmacy First Plus. And there's a huge drive, a huge emphasis from the government, and it's being adopted that the general public first engage, pharmacy first, clues in the name, with the pharmacist, and they go there first if they have any issues. And effectively, they're filtering and screening and appropriately recognizing and sending on into specialist care if necessary. But the pharmacist is empowered to supply, and we're not going to use the word prescribe, but supply and engage with a number of conditions. In Australia, there's an example for you that really brings it home. Pharmacists are facilitating setup on PAP therapy for OSA. So it's a, if you look it up, it's called Pharmacy Sleep. I think there are probably 30 or more, I think even bigger. A well-known PAP manufacturer owns the chain. And yeah, so pharmacy really, they've leveraged the frontline role of pharmacy. So what we've got at the moment then is that they're highly accessible, they're still underutilized, they're trusted by the general public, but they really don't know enough to help people. They are already pushing weight loss services. I say pushing, that's probably the wrong word, but they will provide total meal replacement and calorie control. And one of the beautiful things about the community pharmacy is that they're accessible. You can go there. You can, for people that have total meal replacement, they don't go to the supermarket anymore. They get their food from the pharmacy because it's, geographically, it's local. Around the world, you can find that there are deserts in terms of GPs or PCPs, large regions of every country where there are no GPs, but there's still a pharmacy. And what you'll also find is that ethnic minorities will train as a pharmacist and then go back to their community. So there's, access is not a problem. So they're supplying already GLP-1 agonists for weight loss. So it's right now. Now, the next question then really is, what are they going to do in the future? So I'm advocating, and what we're trying to do in the UK is give the independent evidence-based education to the community pharmacy team to get them to do certain words. I'm going to try and get them to stop using the word diagnose, but assess, screen, recognize instead of diagnose, and signpost. So that the key role for pharmacy already is signposting the right patient, the right place at the right time. So they can also facilitate home sleep apnea testing. I mean, they could also go on and do PAP resupply. Look, here's your new mask. It's all sorts of ways in which we can optimize and better use our secondary care services. So there's ways in which it can change. And already, as I say, they're doing GLP-1 agonists. What's not to say, I can't get a crystal ball, but what's not to say they be prescribing OSA meds, apnea med, Incanex, in combination. Anyway, I'm not, that's a prediction, and I'm not in that business. Okay, so let's now turn to what pharmacists know. Well, this is when I ran a project and I crashed and burned, completely crashed and burned on the first attempt to provide education to MPharm, that's the Master's Year 4 Pharmacy. And we couldn't really work out what level of education to give them. And we pitched it all wrong. We had a 3-hour workshop and we came in right up here and they just didn't grasp it. So we had to, we were dynamic. We brought it down to simple terms. We thought still couldn't get it. So we went away, licked our wounds, and I brought in a professional facilitator, and we started right at the beginning. And it's a shocking realization that you really do have to start at the beginning. So I'm now running workshops at King's College in London, and from year 4, and it's relevant because these are baby pharmacists, if you would. And they just are so uninformed. A 4-year degree, and I'm just picking them up in year 4 before they walk out the door. They've already actually been in pharmacy and had their placements, and they're still so naive and so uninformed. And yet, anecdotally, 1 in 3 of their consultations will be with regard to a sleep. It's a massive blind spot, and we have to address it. So what I'm doing, so with Sapphire, which is sleep awareness and professional health innovation and rigorous evaluation, it's an article that I've written, we've done the research, it's been submitted to the American Journal of Pharmacy Education. It's in review at the moment. And it was a CPD intervention, continuing professional development intervention. And what the outcome was, is we could improve confidence in a 3-hour workshop, and to some degree improve their knowledge. Not a great degree, but we can improve their confidence and dispel some myths. What we also found is that they are already in year 4 of university, but because they've had placements, they're subject to commercial influences. They already feel that consultation is very time bound, it's time critical, and because it's kind of a retail environment as well, there's a drive to sell something and an expectation on the patient's part to walk away with something rather than advice and guidance. So it all, it changes where you are in the world and the perception that the general public have when they engage with pharmacy. But as everywhere, time constraints are a barrier. But what I would also want to finish on this point is that there's a really strong willingness to help from pharmacy if given the tools and training. They're just so appallingly naive and uninformed. And I'm going to rephrase that. They are misinformed, already misinformed. And that's a sad story that I want your help to change. So then I put it to you that pharmacists are sleep health first responders. They're positioned already. They're geographically dispersed. They are there in the community, meeting people where they are. And they're positioned for early identification of insomnia and obstructive sleep apnea. And then if we can stop them talking to patients and getting them onto pharmacological solutions and actually starting them to talk to them about sleep, more than just sleep hygiene, but behavior change. And they're ready there. And pharmacy actually is one of the biggest advocates of deprescribing. The more progressive pharmacists, they don't want to be putting people on medication. And frankly, who better than a pharmacist who's entitled to question the prescription? So if a prescription comes through, it's actually the pharmacist's role to question it and go back, but they don't know to question it. Why is this patient for the 2nd year on a Z drug? They shouldn't be. Something's wrong. But the pharmacist doesn't even know to ask that question. Well, they have high community trust, they're accessible, and they are able to triage with the stop bang, the ISI, and signpost appropriately. All right, let's go to some case studies. Is everyone with me so far? Okay, all right. Okay, thank you. I can just about hear a murmur. All right. Feel like I'm talking to myself. So let's keep going. Case studies. Okay, I'll give you an example. These are real. It's a lady called Claire, name changed, 42-year-old woman, long-term use, short-term sleep aids. She'd become dependent, at least psychologically dependent. It's arguable, perhaps, whether you can become addicted to sedating antihistamine, but at least she didn't feel that she could go to sleep at night without having taken a sedating antihistamine. And rapidly become habituated to it. So she'd be taking 2 or more. And the stats around accidental death are horrific. We're seeing combinations of street drugs with sedating antihistamines, and they will become we believe, I'm speculating, they will become notifiable substances on post-mortem. And I'm talking diphenhydramine hydrochloride, and promethazine, these awful drugs, and street drug users do not know how to combine them. So if you read the book, that wasn't what I meant to do, but thank you, Robert. Overdosed is a second book, and you will see that there are some horrifically powerful drugs being. It's a fictional story based on fact, unfortunately, where drugs are coming in from China in the post, and they're billed as sleep aids, but they're combined with horrifically powerful drugs that will kill you. Okay, so no referral was ever made, back to Claire. No referral, no follow-up, escalating dependency, worsened sleep outcomes. Okay, let's talk about Malik. 55-year-old man, trivialization of sleep, OTC, vendors filling the void, community pharmacy, kind of an evidence-free zone. Terrible situation. Hypersomnolent, snores, asked the pharmacist for advice. They were given nasal strips and throat sprays. Never once asked about OSA, no referral made, undiagnosed moderate OSA for years. You know, consequences, he's driving, he's hypersomnolent, it's horrific. And there's an opportunity there was lost for early intervention. We can change this. This is your undiagnosed population, people. This is what we can do to change it. The stories get a little more grim now, and then we're going to do the Disney thing. I'm going to upset you, and then hopefully I'm going to bring you up the other side and make you happy. Okay, this one comes with a warning. All right, Alex. This is a sad story, I have to say. 36-year-old man, Alex, name changed, lived with his wife and 2 children. And this history was taken from his wife. And you'll learn in a minute why. He went to his GP with the following symptoms: excessive tiredness, struggling to cope at work, and feeling really low and depressed. So Alex started to have difficulty with performance at work due to persistent tiredness. Now, I'm sure you know these stories. You're familiar with this. But it's sad, and we've got to change this. His fatigue put a strain on the couple's marriage, and his wife thought he wasn't contributing to childcare, and she perceived his inaction as laziness. Alex was prescribed, as you'd imagine, antidepressants. Well, who wouldn't be depressed? It didn't help lift his mood, and his wife noticed he snored loudly, and she would frequently think he stopped breathing. As far as she was aware, though, sleep was never discussed by the medical profession. And then when medication failed to make Alex feel better, he started using alcohol. After a few months, he became dependent on alcohol and lost his job. After he arrived at work, drunk. His mental health continued to deteriorate. And the warning here, Alex purposefully ended his life. He leaves a wife and 2 kids, aged 14 and 11. It's an awful story. Absolutely awful. Okay. OSA was never considered, and the point here is that nobody thought to ask him about his sleep. He attended a pharmacy to collect prescriptions. He picked up his antidepressants, but no one thought to ask him. Okay, flip the switch. Let's talk about John. 47-year-old man, self-employed, but unable to work due to extreme fatigue. Now look at the expense. Look at the investigations that went on. Yeah, I mean, it's just crazy. So he was treated with lansoprazole for his esophageal reflux. He's on hypertensive meds. He had classic morning headache, unpleasant taste in his mouth because he was, sucking up from his acid from his stomach. He had difficulty focusing his vision in the morning. difficulty concentrating, had no motivation, ESS of 18, stop bang of 5 because he was under 50 and he was under 35 on his BMI. But he waked on average once a night to urine at 8 o'clock at night. He'd have a ginger tea. And look at these investigations, the cost. He had a brain scan and multiple nasendoscopy, blood tests, chest x-rays, eye tests, medication for hypertension, reflux, nasal congestion. Everything came back normal. Nothing to problem, but he's still exhausted, absolutely exhausted, and he's self-employed, he can't work. Eventually, he saw a sleep-trained pharmacist, one that actually had undergone some education. Initial sleep assessment, recognized the symptoms, referred to a PCP for a home sleep apnea test. This patient was then diagnosed with severe OSA and started PAP therapy. I can't comment on how effective it is because I don't know and how they're getting on. Yeah, but the point is, he was unaware of this, and he snored excessively, and his bed partner was unaware that he'd stopped breathing at night because she'd left the room. And it just continues. It doesn't resolve it, but the snoring was so bad she left. So an incredible waste of time, clinical time, resource use, and huge amount of money wasted. All right, let's turn positive. Let's be happy. I've met this lady, and her name's not Ruby, but Ruby worked in the community pharmacy, and she's a 27-year-old woman. She was big, and she was sedentary. She was constantly tired. Repeatedly investigated for hypothyroidism and anemia and GORD, prescribed antidepressants and omeprazole, really struggling with fatigue and trying to do her job. Initially, Ruby resisted the sleep investigation. She thought this was about the patient. Couldn't possibly be her because she saw the patients were predominantly male, predominantly 50s. Couldn't possibly be her. And she believed in the stereotype. So she didn't want to engage. But the pharmacist, Gareth Evans, who's president of the BSPSS, he persisted. He could see it. He knew what he was looking at, but he wanted to get some data. Eventually, she did a home sleep apnea test, and the results were staggering. And he couldn't believe it. And he thought, there's got to be an error and implausible. Anyway, an urgent referral was made into secondary care. And yeah, an AHI over 70, 74 if I'm actually correct. She's now on PAP. Yep, I've spoken to her. She had some initial difficulty with the mask, as you'd imagine, but she gets lots of good support and she is transformed. She can, and at 27, you would hope that it's improved her life expectancy and need for further medications and support. As I understand it, she no longer has the reflux, halitosis, that sort of thing. So yeah, she's struggling, but she's getting there. And when she gets a good night's sleep, she's transformed. And a line she used, I feel like champagne. I feel fantastic when I wake up. There's no this morning headache. It's just I feel alive and alert and bubbles, Okay, so let's move forward then from product to practice. So what do we want? So the key thing I want to get across here is that what used to be called retail pharmacy, or community pharmacy, these guys have to run a business. It's a business. And even with systems like we have in the United Kingdom, the NHS, community pharmacy has this blended or hybrid system, blended revenue. So they have to earn some money. So that's what drives, unfortunately, that's what drives OTC sales. You go into pharmacy and you can see bottles of shampoo, even perfumes and goodness knows what. I think that the whole system is changing. Professional pharmacy services, and in Scotland, let's take that as an example, as the leading light and leading the way. It's not walking into a retail store. it's walking into a health center. And there are by the way, lots and lots, I think almost all pharmacies in the United Kingdom have consultation rooms. So you can have a private consultation. Weight management, blood pressure checks, these things are actually pharmacies compensated for. And the big thing here that I want to get across when we refer to retail pharmacy is that they have to be compensated for their time. And there's an expectation in the general public's mind that they walk into a pharmacy and they're like a doctor. Their time is paid for, but no, it's not. So too often in the pharmacy sector, they're expected to do things that are not compensated. Now, what they need to move from retail to professional healthcare services, professional pharmacy services, is education. Evidence-based, independently created education. And on top of that, they need to know what are the questions to ask to get the right answers to then inform the next healthcare professional. And to do that, the most effective way, I would suggest, is using a clinical decision support system. It's effectively a decision tree. And I would advocate, and I'm going to put my hand up, I've designed one, a clinical decision support system expressly for pharmacy. It's quite simple. It incorporates all the necessary tools, but the point is, get the data, save clinical time for the next healthcare professional, and put the patient in the right place. We need to have these referral protocols. They need access, and it needs joining up, and the ability to read and write to the healthcare, health record. It's just absolutely staggering when you think about it. The pharmacist has a sort of a 2-minute consultation. They've got no evidence, no access to the medical records. They don't know the patient's name. And they are totally dependent on asking a few questions and trying to work out what's going on. They don't know what current medication they're on. They don't know what other investigations and diagnosis has gone on, unless they've built a rapport, unless they recognize them. But it's all so hit and miss. So we have to change that. And as I mentioned before, we must work on a way to compensate pharmacy for their time. If they're not paid, they won't do it, and they'll just sell an OTC product. And I don't want them to do that. It doesn't help anybody and just causes delay. I think a damn good question to ask would be, well, why isn't this happening already? Well, it's not happening because, as I was mentioned at the beginning, I think pretty much everyone thinks that the patient journey begins from the primary care practitioner. And we're only really interested when they get to secondary care. That's where all the knowledge is. That's where our PSGs are, and we can do all the assessments and diagnosis, and all the expertise is in secondary care. But go to the other end of the patient pathway, and it's an evidence-free zone, and pharmacy has not even been considered part of it. And there's this inertia. I mentioned before the reimbursement is an issue. And also we've got regulations. Depending upon where you are in the world, some regulations permit the pharmacist to step out from behind the counter and actually talk to a patient and have that consultation, even supply medication. But in other parts of the world, it's certainly they may not. So it's changing. And the key bit I really want to add is that the workforce is there, they're willing, and this is where people are. So I'm going to ask you the question. Are you still comfortable saying 80% undiagnosed in 2035? I put it to you that pharmacists are ready. And the question is, are we? Community pharmacy, I would suggest, is not the problem. And it might well be the missing link. I don't want to be part of the generation that saw the solution and walked past it. And I'd be ashamed if we're still quoting that same 80% undiagnosed stat in another 10 years. To me, it's no longer a data point. It's an indictment. So you know what pharmacists could do, and I'd invite your collaboration, clinical, academic, or policy to rethink what frontline sleep care looks like. There's my QR code that takes you to my LinkedIn profile. I'd be absolutely delighted to connect with you. Thank you very much. But before we end, something completely different. Awake check. So yesterday I launched a UK project called Awake Check, awakecheck.co.uk. And it uses the stop bang, the ISI, and then optionally the FOSC10. And the idea is to get a up-to-date data on OSA and insomnia prevalence in the UK. The data we have dates back to 2013, but the study was done in published in 2015 by the British Lung Foundation of OSA prevalence. But we really don't know much about the prevalence of insomnia. We've got some groundbreaking studies in 2019, Adam Benjafield's OSA global prevalence, 1 billion on the planet. 2025, I think Adam Benjafield did another study on insomnia prevalence, but these are all estimates. So if we can get a UK prevalence assessment done, then we change the data, which informs action and policy. So that's what it's about. And I want to mention we've got an absolutely fantastic team, and I'm delighted to lead. So there's myself, Phyllis Murphy, who's used to run a sleep unit in Scotland for 20 years. Adam Patterson Rathbone, he's a pharmacist at Newcastle University, works part-time part of his time in the sleep unit there. Wolfgang Jackert, who's my PhD promoter from the VUB. He's a biostatistician for the European Medicines Agency. Here's a name you may know, Alexander Sweetman, the man that can lay claim to coining COMISA as a phrase, comorbid insomnia sleep apnea, and Adam Benjafield, the name we just mentioned, and then doesn't really need any further introduction. And then Daniel Perez Chada, who published a study in Argentina about the stop bang and its use through news outlets. They managed to get something like nearly 6,000 responses to form a good assessment using the stop bang of OSA prevalence. So how you can help? Follow awakecheck.co.uk and visit the website. Follow us on social media. Share the projects. I really don't need you personally or American citizens to partake, but if you could follow us on the UK and amplify the noise, it would really help. And that's me done. Very well ahead of schedule. And thank you very much.
Do you have any questions? This is a super quiet group today. Adrian, thank you so much. We appreciate it. What time is it where you are, by the way?
It is now 2:30 in the afternoon. Okay. Time for tea.
Get you up early. Fantastic. Thank you so much. Great information. And Adrian, cheers.
All right. Thank you very much indeed. Take care, everyone.
All right, so we will expedite our schedule just a little bit since our speakers they apparently talk really fast or didn't prepare enough material. No, I'm just kidding. So why don't we come back at 10:15 and we'll start with our next speaker. So you've got a little bit of a break. Please spend lots of time with our vendors and talk to them about all their great products and services. And we'll see you at 10:15.
Hey, how was it?
Great.
Oh, I don't know. I've got no feedback. I can't tell.
It's a quiet group. It's still early. These are night techs, so
more caffeine. All right. I don't know if I'm coming in really loud across the whole room, so I'll...
You are, yes, sir.
Okay. Enjoy your coffee, everyone. Bye-bye.
Have a good one.
Cheers.